Hello and welcome to yet another episode of Doctors In. Today we have with us Dr. Rami, who is a consultant spinal and orthopedic surgeon and also the medical director of Dr. Rami Center in Healthcare City, Dubai. Let's welcome him to the program. Welcome, doctor.
Yes, hi, good morning.
First of all, we would like to know more about you.
Actually, I am a Syrian doctor who graduated his basic degree in Syria and migrated to the United Kingdom, where I lived for something like 12 years and did my surgical training in the UK before I moved back to Dubai. I have a general training in general orthopedic and sport injuries and spinal surgery in particular.
So now, doctor, what is the actual need for a spinal surgery?
Well, spinal surgery is quite wide filled. Actually, we do deal with trauma cases, we deal with deformity cases, we deal with degenerative cases, which is age related, and we also deal with some pathologies which cause some neurological problem affecting the spinal cord or isolated nerve roots across the spine from top to bottom.
What are the new advancements that has come in spinal surgery?
Actually, spinal surgery has advanced significantly over the last 10 years. The old method used to use external fixator rather than inside the vertebra, but over the last 10 to 15 years, we are using what we call pedicle screws to hold into the vertebra, and that allow us much more ability to correct deformities and to stabilize the spine in a much better way. And obviously there has been significant advance in the type and manufacturing and biomechanic design of these screws across the last 10 years. Now we have various type of things which we can use for minimally invasive surgery, we can use to inject within the screws, etc. So it has become quite versatile actually. There's many options for the surgeon to choose from according to the case he want to do, and that allow optimal achievement actually in terms of like successfulness.
Okay. So now what is spinal minimally invasive surgery?
Now we tend to avoid, if we can, exposing the spine fully. We try to do the operation in small incision to avoid the dissection of the muscles around the spine. This will also allow early rehabilitation and early discharge from the hospital and minimal complication. It's a lot of things we can do now under X-ray guidance and under some other modalities of guidance to achieve the surgery in a small incision without exposing the spine significantly. Not all the operation can be done this way. Obviously, sometimes we still have to use a classical approach, but we have to analyze the case and see what's suitable. But it's certainly a way to start to advance it into doing much more complex surgery like deformity surgery using the minimally approach surgery. Some surgeons started developing this technique, and it is promising actually, but there's still some limitation. You cannot do everything in a minimally invasive technique.
Okay. So what are the common deformities in a spine?
We deal mainly with the two deformities, like what we call it scoliosis, which is S shape of the spine deformity, or what we call it a kyphosis, which it is the inclination of the torso forward.
Okay, could you just explain that in more?
Yeah, I mean basically this deformity happen usually in adolescence life, where there's some diseases affect the spine and can lead to this deformity. You can see the spine rather than being straight, it's sort of like curved in the sagittal plane. And in the coronal plane, it depends on the, and sometimes in combination of these two planes. So this is what we call scoliosis if the spine is on a sort of S shape. But if it's the torso is bending forward, we call it kyphosis. Now this is sometimes is a minimal, and a lot of we found it by screening program, and people sometimes do not really feel that they do have such a deformity. but it is there, and sometimes does not progress and does not affect the life significantly. But sometimes the deformity is quite extensive and can affect the general function and appearance of any patient, and sometimes we have to operate on that to correct to the best we can.
So now what is the advice that you usually give to the patients?
Well, in this type of deformities, usually we analyze the deformity and the magnitude and the start age and the peak growth period he is in, and see if the deformity is likely to progress or to maintain itself. And we do have a natural history and some parameters to judge every case according to that. And after that, we will advise the patient, well, okay, you need only observation every 6 to 12 months or every 2 years, or we can sometimes treat temporarily in a cast brace of the spine just to prevent progression of the deformity. And sometimes we operate to correct the deformity. Sometimes we deal with children where they are still growing, and we have a different technique for these children, like doing magnetic rods and elongating rods, where every few months we can have to really do some adjustment on this rod to make it longer, allowing the growth of the normal child to happen until certain age where we can fuse his spine in certain position. In that case, he can continue his life actively in the best way.
For how long will the patients have to be hospitalized?
It is actually variable, but it is about anything between 2 to 5 days. Sometimes in minor corrective surgery, they can leave the hospital in 2 days, but if the surgery is quite extensive, most of the time they require 5 days just to make sure that they are stable in terms of blood pressure neurologically, and they are able to mobilize with some help, obviously, until they can go home and rehabilitate further.
Okay. So now what are the challenges that you have faced in your career? Could you just tell us?
I mean, spinal surgery is quite a detailed field. It is not easy surgery, and every patient carry with him a lot of suffering. We try our best to relieve that suffering, but again, we do suffer sometimes because some cases are really very difficult, and you cannot guarantee optimal result even if you do the best job in the world. And also our job would carry a risk of complication, although the risk of complication is narrow, something like you're talking about 2 to 3%, but even this 2 to 3% sometimes can be serious because it is affecting the nervous system, where any little damage to one of these nerves can be substantially affecting the patient. So this is something we face, but well, thanks God, it is not something like major. Most of the complication which happen in our way is under control and usually recover within a certain period of time. This is not necessarily related to a human error or equipment failure, etc., but sometimes related to the complexity of the case. We have a lot of monitoring devices, particularly with deformity surgery, like neuromonitoring devices which we put during the surgery. That will give us an indication if we are pulling too much on the neural tissues. In that case, we will stop it. This is because basically the patient is asleep and you cannot test him during that way. And sometimes if you have a big deformity like 60, 70 degrees, and you are correcting this deformity back to neutral situation, without any doubt that you will have some pull on the neural tissue. Sometimes this is not affecting the patient, but sometimes it does. And neuromonitoring usually help us identifying the problem during the surgery time. In that case, we can release it rather than waiting for the patient to wake up and find out later that he has something, take him to the operating room again and do it. So we have a lot of techniques and technology helping us to reduce the chance of complication. But whatever you do, there is still percentage, 1, 2, 3%, which we still have some complication. And this is for us is a big challenge because even if the patient is very cooperative, understanding the risk of complication and accepting the complication if it happened, it's still a challenge for the surgeon because he's first of all trying his best to avoid any complication. Now, if the complication happened to the patient, the surgeon will be really suffering much more than his patient, not from medical legal point of view, but as a human being, because his duty is basically to try to do the best to the patient, and he will spend another few months or probably a year or two with this patient trying to improve things for him. So it's always a challenge, but we love these challenges because we are designed as professionals to do so.
Okay. So what is the minimum time to do the surgery? Is there any minimum?
Well, again, it is very variable, depends what we do. If we are doing an operation on a little child to put growing roots, this operation can take 2 hours. If we are doing very complex scoliosis surgery, this can be taking up to 5 to 6 hours. Depend on the facilities and depend on the number of assistants and the surgeons, but generally speaking, yeah, anything between 2 to 6 hours depends on the complexity of the case in general.
So could you just tell me about a patient that comes into your mind when I ask you a question like this?
Actually, we come through a lot of success stories. I mean, with the scoliosis surgery, young ladies are the most sufferers from this condition, and they are really within that age where they need to go to school, and they feel embarrassed that they do have a big curve in their spine, and they don't like to go to school and try to keep home, don't like to mix with people. And that can stop a progression of their life and education and being a wife and mother, etc., etc. So I still bear in mind on somebody which I operated on about 9 years ago. I think she was 14 years, and she has a big deformity in her spine, which I corrected, and we achieved very good recovery, and psychologically she is very fine. I think she got married 2 years ago, and she invited me for her wedding. And it was I went there, and it was a nice celebration, and now she is a mother, and her life has completely changed. You feel very happy as a doctor. Yes, you did your duty and you have no favor on that patient, but you feel happy that you achieved something which is substantial in terms of changing a life of herself, her family, her parents, her children, completely. So yeah, we got the reward on the human side as well.
So now what are the treatments that you do for instead this surgery?
There's few alternative treatment came up now in spinal surgery, particularly for disc surgery. We do some what we call it percutaneous annuloplasty, like we insert a needle through the skin under X-ray guidance or a CT guidance into the disc space, and we can do some resection of the disc. I mean, this would not remove the whole disc material, but would remove some. In that case, the pressure within the disc space reduce, and that can relieve the pressure on the nerves. On the same approach, we can do, or it's not a new technique, but it is already there, like we insert like a radio frequency probe, which generate heat within the disc, and that allow the disc to shrink and also to reduce the volume and pressure, and also relieve the neural tissue compression. There's a new technique also using laser, but all these techniques are not 100% successful, and we have to be honest, advising that the success rate is usually 60 to 70%. And because of that rate, we do not tend to use them as a mainstay of treatment. We do what we call a patient selection, where we feel that, well, okay, the pressure is light, and the disc is just confirmed to one side. In that case, if we feel that will probably raise the success rate if we do proper patient selection.
Okay. So now, for how long you have been into this field?
How long I've been in here?
Yeah, in this field.
Well, I mean, in Dubai, I've been for 4 years. In this place here, we have our spinal surgery center here for nearly a year.
Okay.
And we are proud that we are trying to achieve, you know, a high standard service, all evidence-based medicine, where we do not really offer unethical trials or biased opinions and etc. So we try to really make our practice as evidence-based, which is internationally agreed treatment, which rather than, well, okay, having a certain set of practice, I would say.
So lastly, what is the advice that you would like to give to the patients or the viewers?
To the viewers, basically, I would say, well, I'm sorry if one of you have any disease, but each problem has its own solution. So please do not hesitate to see the relevant and well-trained doctor or surgeon regarding any particular problem you have. I'm sure they are the great helper. Just make sure that you are picking the right person, right center, right atmosphere for any procedure you are going to do. I mean, it is a one-to-one relation, the surgeon-patient relation. Surgeon has to be comfortable, and also patient has to be very comfortable. Therefore, you know, taking few opinions, it does not really harm at all, because you can tell that you are feeling more comfortable with particular surgeon rather than other. Always try to get options for your treatment. Do not stick to one option given by one doctor. There's always many options, but obviously these options vary in the success rate. And what we will try usually to give our patient, what we call it informed consent or informed options, like we give him all the options with various success rate and plan the treatment together. In that case, we reach our goal in a successful way. A lot of treatment usually have a success rate of 50 to 60%, whereas for the same disease, there's much more aggressive solution but carry a success rate of 95%. So we cannot really tell the patient, well, you just have to pick that choice. We just have to really give him the options, and sometimes really guide the patient to see one of your colleagues if he does something which you do not do, just to make sure that the patient gets the best.
So doctor, that was nice talking to you. Thanks a lot for being a part of our program. So that was Dr. Rami Hamid with us. Until we meet next time, this is me, Naina, signing off. Take care.